Welcome to Between the Lines with Martin C. Weiner. Today we're going to discuss a chemical called DCA. In 2007, researchers out of the University of Alberta discovered that it had remarkable potential in animals to cure all sorts of cancers, at least put them into remission or to decrease their size. The problem with the drug, of course, is that it's not patentable, and as such, there's been very little attention, if any, from the drug companies. Researchers from the University of Alberta have since solicited private donations, philanthropic donations, to start a human trial, and that news was released just this week with some, again, remarkable results. We have with us today Dr. Akbar Khan and Dr. Humaira Khan from Medicore Cancer Centers, and they administer the drug DCA in what's called off-label, but they administer to cancer patients right here in Toronto, and we're going to discuss the issues of DCA, its funding, and its use. So welcome both.
Thank you.
Thank you, Martin.
Thank you for coming. Dr. Akbar, tell me about DCA in general. What is it?
DCA is it's actually a very simple chemical. If you look at the name dichloroacetate, acetate is like acetic acid, which is vinegar, and dichloro, two chlorines, and it actually has sodium in as well, which is sort of like salt. So in simple terms, it's kind of like salt and vinegar put together. A very simple molecule.
Salt and vinegar. And I've been eating that all those years. And so, but I think you immediately get to the problem of the chemical. I mean, salt and vinegar doesn't sound like something that you can patent.
That's right. It's not rocket science. It is a very simple chemical. It's been around for probably about 20 or 30 years. It may have had a patent at one point. I'm not sure, but certainly does not have a patent now because it's an old chemical.
Now, I understand that the same chemical has been used in humans for a disease. I believe it's called lactic acidosis. Am I correct?
Yes, that's correct. It has been researched quite a bit for a disease called congenital lactic acidosis.
Right.
There's a lot of studies coming out of Florida, out of the university there. So there's a lot of human experience with the drug, and there's a good safety profile that's been demonstrated by their research. So it has been used quite a bit for that, and it's actually approved in Ontario for that disease. Now, that is a very rare disease. We see very few people. I've actually never seen a patient with that, but maybe a few in Canada every year are diagnosed with that. It's very uncommon.
Okay. So that being said, though, there has to be some data as to how this drug reacts with humans.
Yes, I mean, that's exactly for that disease, for the congenital lactic acidosis. There's a lot of research in humans, more in children, but the human data is there, and it shows, basically it shows the safety profile of the drug. It shows what the side effects are. So we're quite aware of how the drug reacts in humans.
Okay. So, Dr. Humaira, I'm just going to omit the Khan if you don't mind, because we won't know who we're talking to. Can you tell me a bit about the original discovery in 2007?
Well, in 2007, researchers at the University of Alberta basically had taken human tissue, cancers from the brain, lung, and colon,
breast.
And breast, and they had transplanted into rats and given them dichloroacetate, and they realized that after a few weeks of treatment, the size of the tumor shrank considerably. So based on that, there was a lot of excitement because that amount of shrinkage had been seen before, and it was hoped that those results in the lab, in the rats, could also be reciprocated in humans. And based on that research and the fact that DC had been around for a while and there was human data available, a lot of patients came to us saying, there's this research, is there anything we can do with it? And that's when about 2.5, 3 years ago, we started giving it to our patients.
Okay. We actually have a slide of that, of the progress in rats. We've got a picture of, it's almost a famous picture now of the 3-week course of a tumor decreasing over the course of 3 weeks. But one thing about that, and maybe either of you know, what sorts of doses were given to achieve that result?
Well, it's it's hard to really get any meaningful information from that because a dose in rats is not equivalent to a dose in humans.
Fair enough.
So I actually don't know the number offhand, but it's not directly comparable. So whatever dose that was, I mean, that's why a rat study is a rat study and a human study is a human study. Because even if that dose seemed reasonable in a rat, it doesn't necessarily mean that the drug will still work in the human.
Well, I get the impression that it was a rather high dose, whatever that means objectively. But the reason I say so is because the latest bit of news that came out of the University of Alberta seems to suggest that it takes up to 3 months to build up a metabolically suitable amount of DCA. So it's hard for me, just, I do have a biology background, I never mentioned that, by the way. It's hard for me, even just as a scientist, to figure out, like, what does that represent? Does that represent in a human a dose that would really basically immobilize the patient with side effects? Or do we have any guess as to...
Yeah, I think it was a relatively high dose. Now, in humans, the doses are kind of limited by the side effects of the drug. One of the main side effects is a type of nerve damage. In rats, I don't think they actually observed that.
Oh, really?
I don't know if they could actually measure that in the rat, but in humans, the dose is limited by the side effects. Now, it is better in terms of treating the cancer to use a higher dose. It does seem to be more effective. That's our experience. But the limitation is the side effects.
Okay, so you're getting somewhere where I'd like to go. So basically, it was up to you to develop sort of your own protocol in a sense as to how to administer this drug.
That's right.
Given that there was no human trial, or that I mean, even in 2010, there's been a very limited human trial that was just announced last week.
Yes.
And that human trial didn't really address much about dosing, if I'm not mistaken. Its main goal, if this is from memory, was to prove that the mechanism in animals was reproducible in humans. In other words, that the drug was having the same effect biochemically in both. So how did you go about coming up with the dosing?
Okay, well, basically we started off looking at the congenital lactic acidosis research. The doses they were using in children ranged from about 25 to 50 milligrams of the DCA per kilogram of body weight. So we looked at that and we said, okay, here's a dose where we know what the side effects are, we know what the effects are in humans. Let's be conservative and start lower than that. So we started at about 10 milligram per kilogram. And so we started treating a few patients. We followed them for a month or two, and at that dose we were seeing very little in the way of response to the drug. So the cancer didn't seem to be responding that much. So then gradually we increased the dose, and we were very careful monitoring patients for side effects. And then when we got up to around 20-25 milligram per kilogram, we started seeing some results. Not dramatic, but we were seeing results. And then we said, you know what, let's try higher. And some of the patients were asking us, please take us higher because, we want to try this. We don't have anything to lose. So we tried higher, around 40-50 milligram per kilogram. And at the higher doses, we definitely saw more response, but we also saw significant side effects.
And just for the viewer, what were some of those side effects? You mentioned some neural toxicities, but I mean, what does that really mean?
So what it really means in practical terms is you can get numbness in the tips of your fingers or in your toes. If you ignore that, you can start feeling pins and needles. It can progress, so not just the fingers, then the whole hand will be involved, or the arm, and not just the toes, it'll progress up to the foot, the leg. And again, if you continue to ignore it, you could get paralysis. Other side effects that we saw were sleepiness, memory problems, confusion, and at the high doses, some patients had hallucinations. They were seeing things that weren't there. There were some behavior changes that we were seeing as well, sometimes stomach upset. Now, these side effects, clearly they were significant. So once we dropped the doses down, then we found that we were able to control the side effects. And then there was the other thing that we found was, because the drug, as you mentioned, tends to build up in the body over time, we found that after 2 or 3 weeks, that's really when patients started to get side effects, when the drug was building up.
Right.
So based on that, instead of doing a continuous treatment, we decided to do an off and on treatment where we would give the drug for 2 or 3 weeks and then give the patients a break. And that allowed the drug to clear from the body, and that helped to minimize side effects.
Mm-hmm. I understand, though, that even in the case of very severe side effects with DCA, they're typically reversible. Is that true?
Yes, that's correct. The worst side effects would be forgetting where you are, start seeing things, hallucinations. That would be reversible in a matter of days. The nerve problem, the nerve damage, the
Right.
so-called neuropathy, that's something that might take weeks or months to reverse, but it is also reversible.
But it does reverse.
It does reverse.
Compare, if you can, the side effects of DCA, statistically speaking anyway, with the side effects of, say, some harsher or some more mainstream cancer treatments.
Well, DCA is very, very gentle compared to the other chemos. Patients who've had chemo, they can be pretty much bedridden a lot of times. There's a lot of nausea and vomiting, which is very limiting. Again, hair loss. So a lot of our patients come to us because they don't want the harsh chemotherapy. So I can't really give you like it's 5 to 1. But compared to those side effects, these side effects are very manageable. They're very short-lived. And again, with a proper dose, a lot of them can be controlled. And the other thing which Akbar didn't mention was in terms of the side effects, especially the peripheral neuropathy, he did start giving more supplements, so vitamins Bs, alpha-lipoic acid, and that has seemed to help the patient a lot. So we can increase the dose a little bit without compromising the efficacy of the drug and managing the side effects at the same time. So to answer your question, I think chemo is so incapacitating in a lot of patients, whereas DCA is a much gentler and more manageable way of treating the cancer.
Mm-hmm.
If I may add, the worst side effects that I mentioned to you they don't happen in everyone. So
Right.
the neuropathy, the nerve damage may happen in, let's say, 20 or 30%. Again, it depends on the dose, and the confusion or hallucinations really probably less than 10% of the time.
Right. We have a slide of your
Right.
side effects, and basically it shows that no side effects are present in about 44%
That's
of
correct.
people.
Yeah.
So and these hallucinations, et cetera, seem to be around 2%. So I mean we're
Right.
So I mean while the side effect itself is pretty severe, it's a very low occurrence.
Right. I mean, that's based on our dosing and our cyclic treatment and our supplements being given at the same time.
So here's a very hard question for anyone to answer, but how do we know that, say, a month of DCA treatment and at a very, very high dosage might wipe out the cancer, whereas minimizing the side effects, keeping the dosage low, we may never get rid of the cancer? How do we come to that decision of, side effects versus cure?
Right.
It's a hard question, and I understand.
Yeah,
but-
it's very difficult to answer that without doing the clinical trial.
Right.
But I will tell you something interesting that we have mentioned briefly on the website is we do have 2 patients who have a complete remission of their cancer.
Yes.
Metastatic cancer, which had very poor prognosis, and the cancers were growing prior to DCA treatment, and the patients took DCA for about 3 months,
Mhm.
and they have no sign of cancer, and now they're 2.5 years down the road and they're cancer free. And those patients, we did not use excessive doses. We did not use 50 milligram per kilogram dose. I believe it was closer to about 25 milligram per kilogram. So we know that you can have a dramatic response even with a more modest dose, but we don't know who is going to respond that way.
Right.
It's hard to predict.
Right, because it's very individual. Just like chemo, some patients respond really good to it, whereas others have no effect. So again, with DCA, we're finding that a lot, that there's a lot of individual patient-to-patient variation. So it's very hard to predict if we give 50 milligrams per kilogram to all our patients. I'm sure even half of them, again, may not respond just because that's the way it's supposed. They just do not respond to DCA. For whatever reasons, we're not quite sure.
Right. Since you deal a lot with the statistics, would you say the bulk of your patients are recently diagnosed, mid-course in cancer, or late-stage cancer?
Well, I would say most of our patients come to us once they've tried other chemotherapies or radiation and it hasn't worked. So I would say, let's say about 60 to 70% of our patients are at that stage where they have given everything a try and their physicians have told them, we've got nothing more to offer you, and so they say, let's try DCA because we really have no other alternative. We do get some patients who are newly diagnosed, and those patients are the ones who have looked at all the options of chemotherapy, looked at radiation, and they've made a conscious decision that we do not want to have those harsher treatments. So if they come to us, we do feel an obligation to, again, give them DCA. There's a small percentage of patients who also come to us because they just want to supplement. For example, if they're getting radiation, they just want to add something onto it. And then there's a very, very small percentage of rare tumors where there's really no treatment available. So they say, doctors really don't know what to give us because there's nothing in the literature, so we would like to try DCA. So again, the bulk of our patients are patients who have tried everything and nothing has worked.
Mm-hmm. So is there any feeling for the efficacy of DCA with earlier or recently diagnosed patients? It's just, call it a hunch, but I'm getting the hunch that the earlier you get to DCA, the more effective it is. Is that a fair statement, or?
I think that's probably true. The data that we have on that is we actually are able to do what's called chemosensitivity testing on some patients. If they have an accessible tumor where we can actually go in and just take a little piece out, we send these samples to a lab in New York, and they're able to analyze and tell us what drug will work on this particular tumor. And we've tested some patients in early stage and some patients in late stage, and the impression we get is exactly what you're saying, that DCA is probably more effective in early stage cancer. And I mean, so is chemotherapy, but that's probably true.
I think even Dr. Mikolakis out of the University of Alberta, he even in his most recent findings seems to suggest that DCA is best used synergistically with other cancer medications.
Yes, we agree with that.
Yeah, it seems to be. So I think actually you said so as well.
Yes, on our website there's some case reports where we have combination therapy with DCA with another drug, and some of those patients have excellent response. We've had patients with devastating brain tumors who are given prognosis of a couple of months who are still alive over 2 years after diagnosis using combination therapy of DCA and other gentler treatments.
Okay. Let's talk a bit about off-label prescribing.
Sure.
Now, off-label prescribing in lay terms, and you can correct me if I'm wrong, is if a drug has been approved for human use, you can prescribe that drug for a different disease. So come up with a crazy example. Tylenol is approved for human use for headaches, but for whatever reason, if you believe that would work for acne, that would be an off-label prescription.
That's exactly correct.
Okay. Now, let's talk about the ethics of that. What do I, as a physician, need to know or be able to prove to, say, prescribe Tylenol for acne? What are the requirements of the physician in that case?
Okay, well, the College of Physicians and Surgeons, who gives us our medical licenses,
right,
they have a policy on off-label prescribing, and
right,
it's available actually to the public, I think, on their website. So anybody can go on and have a look. But in simple terms, what it really is that if you're going to use a drug for an unapproved indication, the most important thing is it has to be done for the benefit of the patient, and the patient has to be fully aware of what are the risks and benefits of the treatment. I mean, that's basically what it is. And once you fulfill those requirements, it's actually legal, it's permitted, and it's very commonly done, actually.
Well, of course. But so there's no requirement of the doctor to produce any sort of preliminary research or any sort of backing research to say this is why we're going to try this, or? Well,
there should be some rationale. There should be some sort of scientific rationale. Like, if you're going to say you're going to treat acne with Tylenol, most doctors would say, well, you're crazy. I mean, that's ridiculous. And I think that would be inappropriate because there's no scientific literature for that. So we do want something to say that, hey, there's some rationale for using this drug for this condition which it's not approved for. I think that is a requirement.
Okay. Would the physician be liable in any sense for say, prescribing Tylenol for acne if there was no rationale, or if they obtained the patient's consent and explained their rationale at least,
Right.
Then there would be no recourse.
Well, if there was no scientific rationale and the doctor came up with his own idea, then it really comes down to risk versus benefit.
Right.
So if the patient feels or understands that there is some potential benefit to taking this drug for the unapproved condition, it's up to them to really consent.
Now, an Ontario colleague of yours, he suggested that he went to the college and said that what you were doing, giving it off-label, is inappropriate, and the college ruled exactly in your favor, saying it's not our place. But more on a human side, I'd like to know, like, that must have hurt, to be honest, because I mean, here you are trying to help patients, doing your best, and yet you're being attacked on these moral grounds, saying that you have no right to be doing that. I mean, any just purely human reaction here. How did that feel?
Well, actually, when we started it, we were thinking that the reaction was going to be much worse than that. So we were surprised that there wasn't more outcry. Having said that, I think it was more of a, we're doing it for the patient's benefit, and the patient should have the right to decide. So really, the attack didn't feel very personal to us, because we knew what our priorities was. And basically, if a patient comes to us and says, I'm willing to try this, I've got nothing to lose, then I don't think it's the right of a doctor to stand in the way when there's something as simple and as safe as DCA to say, I'm sorry, you can't take it. So our motivation has always been to help the patient. And if anyone wanted to complain, obviously they have a right to do that. But we felt we weren't doing anything wrong. So in fact, it strengthened our position.
I thought it was actually kind of funny, because the doctor who made the complaint actually was not an oncologist and does not treat cancer. So it seemed kind of ridiculous for him to make a complaint.
Right. He said
us.
that you are not oncologists, and he himself was not one either. But
That's right. I'm not an oncologist, but I have about 15 years experience dealing mainly with cancer.
Right. Okay. So yeah. Well, no. You must have been strengthened, though. It sounds like, by the results that you were seeing in your patients by that time. You must have been a while in. Am I correct?
I think the first 20 or so patients, we started to see some good responses. So we were really excited, because a lot of lab research does not translate into equivalent benefits in humans. So this was a big deal for us.
Now, hadn't DCA been approved for use in this other rare disorder, this option wouldn't have been open to you. Is that correct?
Not in the same way. There is actually a mechanism through Health Canada to allow the use of unapproved drugs, which basically unapproved drugs, whether off-label or not, and it's done individually. So then we'd have to request Health Canada for permission to use the drug for each patient that we saw. So there is actually a mechanism, but it's much more complicated.
Okay. And besides DCA, do you use any other chemicals that are like DCA? These chemicals that are rarely tried or not commonly tried?
Actually, we do. We have a few different drugs. The first one is called ammonium tetrathiamolybdate, or TM for short. We've been using that for a while. Again, there's a lot of research on that as well, and there's a lot of human data on that drug as well. We've also been using low-dose naltrexone, which is an approved drug, with, again, a lot of human data. We've been using vitamin C. Again, that's not off-label, but
ribavirin is the other one. There was a new study done in Montreal that showed that ribavirin, which is an antivirus drug, has benefit in humans in a type of blood cancer. So we looked at that research and we said, okay, this is very interesting. Let's see if this is going to work in other tumors too. And there actually was data, there was research that suggested that it would work in multiple types of solid tumors like colon or breast cancer. And so we tried it and we actually did see results with it. And that's quite new to us. That's not on our website yet, but we're hoping to write up some cases of that too.
Okay. So we have, you've got quite an array of untried or, recently tried technologies in use at your center. Are you the only one in Toronto or Canada that has this approach?
I don't think we're unique. I think there are a few others doing it, but probably most of them, they don't want to be public. They don't want to go public with it because they're afraid of the backlash, as you mentioned.
And what about in the United States, like the Mayo Clinic? I heard that the Mayo Clinic typically does this kind of orphan drug. Sorry, I haven't explained what an orphan drug is, but that's a rare drug for a rare disorder. They do this kind of off-label prescribing. Is there any statistics or information out of those kind of cancer centers?
Well, I don't have any data from Mayo Clinic about DCA. They may be doing it. If they are, I think that's great. And we actually have patients who go to Mayo Clinic for their treatment as well. But in terms of DCA, I don't know if they're using DCA specifically.
Okay. I think we're going to take a short 3-minute break, and we will be back. Thank you.
Thank you.
Coming album titled Midnight, and the CD release is this Saturday
At the El Macombo.
at the El Macombo.
Yeah.
Saturday, April 17th. So we're officially rolling out. We'll be playing some new tracks off the album, and this feels so nice, doesn't it? Hi, ladies and gentlemen. Welcome to Liquid Lunch. I feel like I'm in a lounge all of a sudden,
He's like the third
man.
host here, eh?
Man alive.
Yeah.
So this is entitled Now That You're Gone. And this song was written by my youngest brother, and it's kind of like a universal kiss-off to the ex-boyfriend, ex-girlfriend, whatever it is. So, here it is for your listening pleasure. I've been tearing up those letters with all those words you ever wrote me, 'cause they were all just words, nothing more, nothing less. I've started walking different roads, trying to get new memories, yeah. And I've been making every effort to forget your name, 'cause I don't want you and I don't need you. I won't do anything to please you, and if you need me, it's too late to call me. Your world should never again involve me, 'cause I'ma be alright now that you're gone. My whole world is so right now that you're gone. I'll be alright. You've been calling me every day, trying to say sorry for how you hurt me so bad. But I think you give yourself way too much credit, more than you should ever have. 'Cause I've been picking up the pieces, never knew it could be so hard, yeah. And with all this work, I realize that I've come so far. 'Cause I don't want you, and I don't need you. I won't do anything to please you, and if you need me, it's too late to call me. Your world should never again involve me, 'cause I'ma be alright now that you're gone. My whole world is so right now that you're gone. Oh, well, if you ever wanna call me, yeah, don't pick up the phone, 'cause it's way too late, baby. I'm not gonna be home. So you can start by putting away all those things I ever gave you. Go ahead and tear up those letters, they must have all just been words. See, I can't be the one for you, only when you need me, yeah. So learn this lesson the hard way, girl, that's what you deserve. 'Cause I'ma be alright now that you're gone. My whole world is so right now that you're gone. Oh, and I don't need you, girl, now that you're gone. 'Cause I'ma be alright.
Okay, for the second half, I'd like to focus on the problems in bringing DCA to market. DCA, as we've mentioned before, is not patentable, and without a patent, the drug companies, typically they make their money by getting the patent, and then that patent gives them exclusive right for about 7 years to sell that drug. And that's how they recoup the nearly $1 billion it costs to get a drug past the FDA approval process. So I guess the first thing is, why isn't DCA patentable? Why can't you patent table salt for the use of cancer? Why not?
Well, the way you patent a drug is because you have a specific formula that you apply when you make the drug. With DCA, as Akbar mentioned right in the beginning, it's such a simple formula, it's such a simple drug that there really is no way that you can patent that technology. What you could potentially do is you could have a use patent on DCA. So you could say, even though the salt or the chemical itself cannot be patented, but we can make a patent, whereas you're not allowed to use it for a particular indication. So for example, if you were to have a use patent on DCA in lung cancer, you could say only the person who holds the patent can use the drug, but no one else can. The problem with the use patent is that it's not enforceable. It's a very weak kind of patent, so most drug companies won't be interested in it. And that's why DCA would be a very losing venture to invest in for drug companies, because there's no way they'll be able to recover the money. And then the problem with that is that if there's no research, most scientific community will never make it to mainstream, because most physicians will not be willing to try it.
Okay. Now DCA is available as you can order it from a book anywhere, a chemical supply store, at pennies on the kilogram, if I'm not mistaken. Am I correct?
Well, you can order it fairly cheaply. There's different sources. There are people that are manufacturing it and just selling it on the internet. Then there's proper chemical manufacturers,
right,
and they make a lab grade DCA, which is fairly cheap, and I think that's the one you're referring to.
Right.
And that's used as a lab chemical in research. And then there's pharmaceutical grade or human grade DCA, which is suitable for human use. Mm-hmm. And that is made at a different facility, a facility that has the proper approvals and the processes in place to ensure that the drug is actually safe for human use, and then the cost goes up significantly.
It's significantly, but still, comparing to other cancer treatments.
Well, compared to other cancer treatments, we're talking hundreds of dollars here, compared to thousands.
Right. So I mean, I don't know if this is a fair question, but would you happen to know the cost of, say, interferon? This is a very expensive course of treatment.
Yeah. I believe it's thousands per month.
Thousands per month. And should DCA be approved eventually in future, do you have any idea how much it costs for pharmaceutical DCA for, say, a month?
Well, if you're making it in large volume, if it's approved and it's being used in extremely high volume, then it's going to be in the hundreds, probably low hundreds per month.
And now?
And right now it's about, how much? About six to 800 a month. That's about what it costs from our pharmacy.
Okay, but still significantly less expensive than most cancer treatments.
Yes.
Even so.
Yes.
Okay. So we've discussed this notion of a use patent. So you can patent, say, the use of table salt for acne or the whatever.
Yes.
These common chemicals for some disease. So you can do that. But you're saying that it's a weaker patent, and what's to stop somebody from just taking table salt, right, and using it themselves?
Right.
Once they know.
They can't. With that patent, they can't stop an individual from actually taking the treatment. They can stop a company from treating a large number of patients. They could probably stop a hospital who's using it. Individuals, it's hardly worth it to chase an individual to stop, to force them to stop using the drug. It would cost them quite a bit of money, and they wouldn't really benefit from that.
Okay. So also, when I'm getting the idea that it's not just so much the chemical formula of the drug that's important, but they get patents over its construction, the way that it's put together.
Yes,
right?
that is sometimes patentable. Yes, that's correct.
Okay, so then the drug company, they're really looking for a watertight patent that is of a chemical that's hard to produce,
Right.
that needs to be produced in a unique way,
Right.
that they have the patent on, and then they're able to recoup this $1 billion that it takes to get it past all the FDA approval process. And let's talk a bit about the $1 billion. By the way, that number is not a number I'm throwing out. That's a Tufts University research has estimated that it would take, on average, $1 billion to get any given drug FDA approval. So with this billions of dollars, just socially speaking, why does it cost $1 billion to get a drug to market? And I'll do something an interviewer shouldn't do, but I'm going to suggest an answer. I have a feeling that it's the drug companies are profit hungry and they're profit driven. So the FDA knows this and needs to put up this high cost of entry, this $1 billion cost of entry, to ensure that what the FDA the chemical companies unleash on the public is safe, because they are obviously in a rush to get everything to market that they can to get as much money as possible. So based on that, and I'm sorry for providing half the answer, but do you have a feeling that's a fair statement or not, or why does it cost $1 billion basically?
I'm not sure. I don't think I can give you a really concrete answer on that, and I'm just be speculating. But I believe what you said is probably true. But also, it does take a lot of money to actually do good clinical research. You need to have multi-center trials. You need to enroll enough patients that you have statistical significance. You need to publish the data. So I do understand that it will cost you an enormous amount of money. The $1 billion does seem excessive. So I'd just be guessing if I say that it's right, because drug companies, they need to make a huge profit margin. They need to put everything out. So they will do an accelerated research. They will try to focus on where they make the most money, and then maybe that's why their investment in there is so high. I don't know if I'm equipped to answer the question.
It's a social question, so.
But again, I think that's what it is. I was not familiar. That's how high the number is, and frankly speaking, I'm quite shocked that it would be that high. Because again, like in our clinic, there's only 3 of us who kind of collect the data, and our main focus is not data collection. So let's say if I had 2 other people who were doing this full time, I'm sure I'd be able to come up with a lot more data. So if you really want to do it properly, it doesn't need that much money. It just needs you to do things in a proper way and to be more efficient. So looking at a drug company, I'm sure that there's a lot of ways they could cut the cost, but there is no motivation to do that.
Well, the reason you're able to collect data at all is because the drug is available off-label. So, I mean, there are other chemicals out there that are not available at all, or at least easily. There's a article here by Ralph Moss. He's an op-ed contributor to the New York Times, and he's talking a bit actually about melatonin, and this is a hormone we've all heard about, and helps us sleep, evidently. But he has said that he has over 100 articles of research about this hormone, and he's conducted numerous clinical trials. But when the author visited him in Italy, he was in deep despair over the pharmaceuticals industry's total lack of interest in his treatment and approach, and he's published nothing since. So, I mean, there seems to be a large class of these cheap but not patentable chemicals that are out there that seem to have a huge amount of promise for cancer, but they seem to have trouble making it to the light of day.
Yes, a lot of trouble. Another one that's very common is vitamin C. There is a little bit of data now that's showing that vitamin C, given in high doses by IV, so intravenous in the vein, can improve quality of life in cancer. And there is some data that shows it can actually enhance the effect of chemotherapy. It's very limited. I'm not sure how they actually got funding for those trials, but there were some small trials done. But here's a simple drug, or if you want to call it as a vitamin, natural product, probably costs about $20 for one intravenous infusion of the vitamin. That's the cost of the vitamin itself, not patentable. So there's hardly any trials out there. And it doesn't look like that's ever going to get approved either for cancer treatment, even though it's very safe and it's very cheap. There's no patent on it.
Well, there has to be some people who have an issue or have something to gain from the elimination of cancer beside all of us. But I mean a financial gain from the elimination of cancer. Take, for example, the insurance industry.
Yes.
You kind of scratch your head and wonder why they wouldn't fund such research. And again, it's a hard question to answer, but and maybe just because no one's ever approached them.
Right. Yeah, it's a good question. I don't know insurance companies funding any research. That's a very interesting question.
The other thing is in Canada, of course, we have socialized medicine.
Yes.
And so Canada, the government of Canada, has a vested interest in eliminating cancer.
Yes.
So you would think that they would have some programs, and I believe you've mentioned some, that would help along these drugs which are not patentable but show promise. Can you tell me about some of those programs?
Well, I believe that there is, I think it's Canadian Institute of Health Research. There is an organization that does fund these types of drug trials, and I know University of Alberta did receive some government funding for their trial.
Yeah.
But I don't think it was, it certainly wasn't enough to run the whole trial. Mm-hmm. And now you can see that this is a fairly small trial. It was supposed to be a 50-patient trial, and in order to actually get a drug to market, to get it approved, a 50-patient trial is completely inadequate. You have to do trials on hundreds of thousands of patients at multiple university centers, sometimes in different countries as well, before you can actually prove to that level of certainty that this drug is effective for this particular disease. And then you're talking big money. Mm-hmm. Mm-hmm. This I believe University of Alberta spent about $1.5 million on their research, and that was a 50-patient trial. So if you multiply that, if you're talking 500 patients, 1,000 patients, you can see the numbers go up very quickly.
I believe he raised $800K.
He raised 800, and I think they got some funding in addition to that.
Okay.
From the government.
Okay. I want to talk another story of research, and this is not cancer research, but it seems to be apropos here. In the late 90s, Australian doctors believed that the bulk of ulcers in the human GI tract were caused by a bacteria. And every gastroenterologist known to man said, no, we're sorry. Bacteria do not live in that high acidic environment of your stomach. We're sorry, that's not true. And it's a remarkable story. The researchers believed this research so much that they actually ingested the bacteria that they believed were causing these tumors. The tumors, ulcers. The ulcers. And the ulcers developed. And then they took a very, very high dose of antibiotic, which they believed would cure this, and they cured themselves. And then they had the pictures of the ulcers, the treatment, and they published that. And then all of a sudden, all over the world, it's almost a household name now. H. pylori. Well, maybe not a household name, but every doctor knows about it. And there's now tests. There's actually a breath test, which will detect H. pylori. So, I mean, what does that say to us about the state of research as far as funding is concerned? To me, that's a dramatic statement.
I mean, that's pretty deplorable that they would have to go through that and that nobody would fund their research, especially when they had preliminary evidence that what they were saying was correct. Mm-hmm. It's such a sad state that it's so hard to get funding for something like DCA or any of these other gentle off-label drugs, because I think they really could be added to patients' treatments once the research is done, because then the medical community would accept their value and would know when to use them. So I think we're really missing out.
And I think, Martin, just commenting on that story, it just shows that perhaps the medical community gets so focused on doing a controlled trial that they discard all the other evidence. So the soft data or the patient's subjective things, sometimes we don't give enough weight to them. And I think maybe there needs to be a shift in the way we look at stuff, because we should not just be saying, I need a randomized trial to prove to me that this thing will work. Well, perhaps if you have 500 patients and they've all seemed to see some benefit, perhaps you should give that some weight, or just not be so rigid that you say, if I don't see the research, I'm not going to do it. So I hope that based on the University of Alberta research and some of the data that we present, that most people would try to see that there are other ways that you can get the data you need. It may not have the rigorous criteria of research trial, but perhaps you need to broaden your outlook and perhaps look at other data and see what is best for the patient.
Mm-hmm. A more holistic approach, at least.
Yeah, absolutely.
But just to stress that the problem with this, with their suspicion again, was that the drug companies weren't interested in the case of these Australian doctors, because antibiotics, of course, are either already patented or it's not a new.
Right.
So we're in the same situation. Mm-hmm. There's more examples of this, and I'm reading from Ralph Moss here. In 2004, Johns Hopkins researchers discovered an off-shelf compound called 3-bromopyruvate, which could arrest the growth of liver cancer in rats. The results were dramatic. Moreover, the investigators estimated that the cost to treat patients would be around 70 cents a day. Yet 3 years later, no major drug company has shown interest in developing this drug for human use.
It's actually even more dramatic than what you read, because we've read the research on that drug, and that drug actually cured the tumors in the rats, which is, if you compare it to what we talked about earlier with the DCA shrinking the tumors in the rats, mm-hmm. in 3 weeks, this drug actually cured them. So you could even say it's a step better than DCA,
right? But
it's another cheap drug, and again, not patentable. And we've spoken to the lead researcher in that study, and she's very keen to get some human trials going, get some human data, but there's no funding for human trials.
And in this case, we're in the unlucky situation that this drug has never been tried in humans. Is that correct?
That's correct. There's no official human trial on that drug yet.
So you cannot give this off-label.
That's correct. Yeah, we've actually asked Health Canada if we could have permission to try this drug, mm-hmm. and they denied us.
Wow. We seem to see a pattern emerging here. Mm-hmm. Cheap available drugs that show promise but get no attention. Just out of curiosity, melatonin, any attempts there or any?
We haven't.
Well, our naturopathic doctor does use melatonin.
Okay.
Yeah, we work with a naturopath in our office. He does use it quite a bit.
Okay, because there's evidently quite a lot of research coming out of Italy on this. Same frustration, same anger.
That's right.
Let me ask you, what do you feel are your hopes for DCA being approved for general use, if any?
Well, we've talked about a lot of things like it not being patentable. So I'm optimistic. I don't think it would come to the stage where we will have so much data that it would be available readily for cancer use. If it does, it's going to take a long time, and it will probably be funded through donations of people, because drug companies are certainly not going to invest in doing research regarding DCA. Hopefully, people will try to see its benefit, and as I said, change their thinking a little bit in terms of not wanting rigid clinical trials to show that something like DCA would work. And I hope more physicians will start prescribing it, and eventually there will be enough body of evidence to show not just the medical community but also researchers that it is a good viable treatment option. So hopefully University of Alberta will get more donations and can do another trial. Hopefully we can collect more data and show again that it does work in a clinical setting in real life situations, and maybe combined we can change people's thinking, but I'm not very hopeful that it would be through a funded drug company research.
Let's talk a bit about the statistics on your successes. I have a slide. It's from your website, and this may be old. Actually, I believe you have more data you were mentioning to me, but you have 60% success rate of positive response. You have 11% indeterminate and 29% no response. So, and then I believe you break it down. You break it down further that in most cases, when there was a response, you have stabilized disease, improved symptoms, and then there's some other. What do you feel about those statistics? First of all, the 60% success rate or positive response.
Well, when we did those statistics in 2009, our patient numbers were about 300, and once we took out the patients who didn't take it for long enough, or basically we couldn't follow them up, we had about 180 patients. So it did give us a lot of confidence in the results, because previously too, with smaller number of patients, we had seen similar responses. So the 60%, it varied a little bit. It was between 60 and 70%, but the 60% seems to be consistent. We've now treated over 500 patients, and again, we don't have that much detail in the data. However, the 60% positive response is again consistent. And when we talked about positive responses, we just wanted to categorize it a little bit better, and that's why we divided it into those categories. Now, those were just arbitrary because we wanted to have some sort of solid proof that it works, which was tumor regression, markers, lab tests, and then the symptomatic stuff where the patient called us and said, I feel great because ever since I've been taking DCA, and then to the what we call the lowest positive response, where the disease didn't progress. So we were very excited about those because, as I said initially to you, these were patients who had no treatment options, or they had rare tumors, or they didn't want to take any other chemo. So having a 60% response rate in patients who've exhausted all other therapies was really, really encouraging. And we've continued to see that kind of a response.
Yeah, that actually is remarkable in a sense. So this is 60%, but that's in people who are not on any other cancer treatment.
That's
They've
right.
gone through cancer treatments,
Yeah.
Or unwilling. So that 60% has to be taken in that context. My question is, do you have any feeling? And I mean, I'm asking you to guess as a researcher a bit, but if you started to take patients earlier, or if you were able to give more patients DCA earlier in their disease, if they came to you earlier, any guess as to where that number might lie?
That's hard.
I think based on the lab testing that we've done with the patient's tumors, and we're seeing that there is synergism or good effect when you combine DCA with certain chemotherapies, I think that if it was possible to use the DCA earlier on, especially in combination with some of the standard cancer therapies, I think we would have much better data. I think a lot more patients would get better, and who knows, you may even have some cures out of that. I'll give you one example. Mm-hmm. We have a patient newly diagnosed with lung cancer who came to us just recently. She's about a 55-year-old lady, and we did a test on her cancer cells to see what would work, and it turned out she was chemo resistant. So the standard chemotherapy drugs, we could, from the test, predict that they would not work for her.
None.
Almost nothing, or very poor response. So all the standard regimens for her type of cancer, very poor response. And the data shows that typically probably about 30 or 40% of patients fall into that category for her type of disease. Mm-hmm. So it's not completely unexpected. However, she did respond to a combination of DCA with a standard cancer drug, a non-chemo drug called Tarceva, which is a tablet. It's a gentler, called a targeted treatment. It just targets the cancer cells. So DCA plus Tarceva gave her a 95% response in the lab test. So we actually went ahead and treated her with that combination because that's what she decided she wanted to do, and she's had a phenomenal response. Mm-hmm. So here's an example of a patient, earlier stage cancer, who has had an excellent response with the combination of DCA plus a standard drug. And actually, we even tested the standard drug by itself, the Tarceva by itself, and showed very poor response. Mm-hmm. So it really is the combination that's working for her. Mm-hmm. Normally we're not going to be doing that sort of thing because that's not a standard therapy. I mean, we always direct the patient to standard therapy, but this patient was adamant she did not want to take chemo, and so she said she'd opt for this gentler therapy. So she got lucky, and she ended up with a very good result. But I think if more research could be done on that, then we could prove that, hey, let's say, for example, for lung cancer, DCA plus this or this treatment might be actually better than the standard treatment alone.
So when this drug first broke the scene in 2007, there was sort of a hysteria over it, and one of the sort of hysterical remarks was one of the researchers saw a future where they would it's the same way we fluoridate our water for teeth. They would add DHA to the water or to sports drinks in low doses to just ward off cancer. Well, I mean, we laugh, but DHA is now in DHA. It's a sort of a brain boosting chemical. It's in all sorts of foods, organic foods or health foods. What do you think, though? Is there any potential for such a thing? For say, just adding it to some sort of holistic supplement or to a tablet?
Well, I think that there is emerging data on natural drugs that show that they do have cancer preventative effect. Like vitamin D, for example, that's a very hot topic right now. Looking at vitamin D deficiency in our population and what the effect of that is on the rates of cancer. And there's actually new data that shows that the doses of vitamin D that we've been giving, that the medical community thinks are adequate, are actually far too low.
Right.
So that's definitely an emerging field, very, very interesting field. Definitely there are natural medicines that will fall into that category.
If you had a wish, any wish, what would, with respect to DCA, what would that be as far as if you had a wish that you could get from the government or from the drug companies? What would that wish be as far as getting that DCA to market or to be better researched? How would that come about?
I think we could do our own clinical trial. That would be nice. I would love to do that.
If you could get the funding.
If we could get the funding.
Yeah, like even looking at the data that we already have, refining it, fine-tuning it, following up the patients, which sometimes we can't do because of our resources, I think that would be huge because we have over 500 patients, and that would give us a lot of valuable information.
And am I correct in saying that as soon as you experience a side effect, basically that's as high as you'll go with dosing?
Generally what happens if the side effect's very mild, and the patient's not bothered by it, then we will not increase the dose further. If the side effect is bothersome, then we usually cut back the dose. We give them a break from the drug first, then we cut back the dose, then we try again. Okay.
And but in a clinical trial, you'd actually be able to push that boundary a bit, wouldn't you?
Well, in a clinical trial, it just depends on what protocol you define, and then there's going to be an ethics board that's going to review your protocol to see if it's actually ethical to do what you're proposing to do.
Of course.
So there's
but I'm
oversight
saying,
to
like,
it.
of course, we know that regular cancer treatments cause a huge amount of side effects.
Oh, tremendous.
Tremendous.
And they get approved.
Yes. So, I mean, just as a scientist, I'd like to push that a bit. I mean, without harming the patient, of course. Right. But to see where that boundary is, and perhaps at the higher doses.
Yeah, if the protocol is acceptable, if the protocol is approved, then quite often, because it is a very controlled environment that you're doing the research in, you can push the dose. And I think that's what actually was done with the recent data that was published from University of Alberta.
The University of Alberta published that data. They didn't publish that 4 out of the 5 patients they had. Help me out on this one. Glioblastoma?
Yes, that's right.
And glioblastoma, I mean, no cancer is good, but as far as cancers go, this is one of the most pernicious.
It's one of the worst. It's
one of the worst to get. That with DCA, they had managed to arrest the development of the disease in 4 patients. That actually, it wasn't published because it wasn't the focus of that, but it kind of leaked out. Right. But they didn't want to publish it because it's not statistically significant. We don't know what the story was, but have you had any experience with glioblastomas?
Yes, actually we have, and we're finding some very good results with DCA. And more recently, we've actually had a couple of patients that took DCA combined with the standard chemotherapy for glioblastoma and had profound improvement in a very short period of time.
Okay, so this is one of those drugs that everyone is itching to try. Everyone in the community is itching to try and hear more about, and I only wish that you continue your work, and I wish you both best of luck in it, and we certainly admire it. And any parting comments? How can people reach you or find out more about you, your center?
Well, thank you, first of all. And we're located in Toronto, and we've got a website, which is www.medicorecancer.com. And I can also give you the phone number. It's 416-227-0037. So if you just Google us, you'll be able to find Medicore. We'd be happy to speak to any patients, answer their questions, and a lot of the information is also on the website.
I think right now, if you Google DCA, you'll find us in the top top page of Google.
Medicore, from the Latin to cure.
That's right.
Oh, very nice. Well, I thank you both for coming by.
Thank you, Martin.
It's been
Thank you.
fascinating.
Thank
I
you.
really appreciate it.
Thank you
so
very much.
Take care. Thank you.